Okay, hello everyone. Good evening. My name is Sana Sharma. I'm the head of Gulabi Punk wing of IMA-MSN Haryana. On the behalf of IMA-MSN Haryana and Be the Women Earth in association with Advamed Hospital Chandigarh, it is my immense pleasure to welcome you all to today's webinar on ovarian cancer. I'm truly delighted to see such an enthusiastic participation from all of you. Just a few days ago, I think not more than 3 days ago, when me and my team were conceptualizing this event, our only aim was to create a meaningful impact. And seeing all of you here joined with us on the YouTube live stream, seeing so many participants join, we're really grateful that you guys are here, and it's just taking a step forward towards our goal. We are gathered here to raise awareness about ovarian cancer in recognition of the World Ovarian Cancer Day, which is observed annually on 8th of May. This initiative has been taken with an aim to spread awareness, encourage early detection, and empower women with knowledge that can save lives. As we always say, the motto of Gulabi Punk Wing has always been for her, by her. We are creating a safe space for women so that they can express themselves. Not only do we take care of their physical health, but also their mental health. This time, we've come together with a shared purpose of fighting ovarian cancer. And I'm truly grateful from the core of my heart that all of you are here. It means a lot to IMA and to the Gulabi Punk subcommittee. Now I'd like to hand it over to Kirti just to give an insight onto people who are behind our back, who have helped us organize this event. We just want to give a thank you note to them before we start.
Good evening, everyone. I am Kirti Agarwal. I am the subhead of Gulabi Punk. On behalf of IMA-MSN Haryana and the Gulabi Punk subcommittee, it is my immense pleasure to welcome you all on today's webinar named For Her, By Her, Creating Awareness About Ovarian Cancer Together. We are deeply honored by the gracious presence of our dignitaries. IMA-MSN chairperson and a well-respected gynecologist, Dr. Punita Hasija ma'am, State Convener Rohan sir, National Council Member Tarun Saxena sir, General Secretary Kamal Mahipal sir, Co-Convener Pariza ma'am, and our Finance Secretary Mihir Budhiraja sir. Your valuable presence and the guidance has meant a great deal to us, and we are truly grateful for your time and support towards our important cause. I would also like to I would also like to extend my heartfelt appreciation to our organizing team who with their hard work and dedication has made this event possible. It was a vision of ours to which has come live in 2 to 3 days. Thank you all my members, Sana Sharma, head of Gulabi Punk, and our team members Faguni, Janvi, and Amira. I really appreciate you all taking your time and making this event a success. Thank you all to faculty members, students, and participants for joining us today and supporting this initiative. We hope this event will be insightful, inspiring, and impactful for everyone. Thank you once again, and I warmly welcome you all. Now, I would like to welcome Janvi to walk us over the basics of ovarian cancer and build a foundational understanding of the topic. Thank you.
Good evening, everyone. Today, I am here to briefly speak about ovarian cancer awareness, an important health issue often called the silent killer because its symptoms can be difficult to recognize in the early stages. Ovarian cancer is the fifth most common cancer among women, with thousands of new cases diagnosed every year. While it can affect any woman, the risk may increase with age, family history, genetic mutations such as BRCA1, BRCA2, and certain lifestyle or reproductive factors. The most important step is the awareness of symptoms. Common warning signs include persistent bloating, feeling full quickly while eating, pelvic or abdominal pain, and frequent or urgent urination. These symptoms may seem minor, but if they occur frequently or continue for more than 2 weeks, medical consultation is strongly advised. Early detection can truly save lives. Doctors may recommend screening and diagnostic tests such as pelvic examinations, blood tests like CA125, imaging tests including ultrasound or CT scans, and sometimes genetic testing or biopsy for confirmation. Treatment options for ovarian cancer have advanced greatly in recent years. New medications and clinical trials are also offering hope for better outcomes. On this World Ovarian Cancer Awareness Initiative, let us encourage women to listen to their bodies, spread awareness, and seek timely advice. Awareness, early diagnosis, and support can make a life saving difference. Thank you. Now, I would like to hand over to Sana to introduce our presenter.
Thank you, Janvi. That was such a great insight that you gave us into ovarian cancer. This event has been in collaboration with the Foundation We the Women by Advamed Hospital. Today we have Dr. Jatinder Sharma, who's the director at Advamed Hospital. Uh, Sir has been working relentlessly for children's health and for women's health in the last 25 years, since 2002. He's been the founder, president, patron of Indian Academy of Pediatrics, Mohali, and an active member of IMA since 2002. He's also the state coordinator for the Triple S program, which is Sankalp Sampoorn Swasthya program, which is dedicated to children's and school health. He's also been an executive board member of IIP Punjab and an ex-executive board member of IIP Chandigarh. He's also been the founder of AdLife Foundation, Jeho Club, Nation First Library, and he's a compassionate pediatrician who is also very active online. He loves interacting with kids and posting videos with them. I think he's very much liked by children. Sir, I really want you to please address the crowd for the next 2 minutes. Uh, sir, can you hear me?
Thank you. Good evening, everyone. It is my pleasure to be with all of you. Once again, I want to convey my greetings from Advamed Hospital to everyone who's participating in this online webinar. I still remember the days of 1999 when I passed from my MBBS, but on those days, we were not this much involved with the IMA. This is very nice of you. You all people are involved with the IMA. We at Advamed Hospital are like working for the women, their health. Our upfront motto is Garb se Go Tak. We treat their pregnancy journey as a player, as a celebration. Along with, we take care of their health problems, physical health problems through laparoscopies, IVF work, and at the same time, we train with the Namata Training Academy internationally and national doctors in the field of laparoscopy and IVF. And as the things are changing very fast, similarly the generations are changing very fast. Most of you are from the Gen Z generation. You have seen this great change in the medical profession along with us. Now AI has come. You need to adapt very fast, but at the same time, you all of you should have very strong basics, because one thing is very clear: AI is not human, and only the doctors can keep the humans as humans, their feelings, their trust, companionships, and all. So you are the torch bearers of future IMA. You will face many challenges. Like in 1999, IRDAI insurance companies came in the India. Similarly, corporate hospitals and the nursing home culture was slowly vanishing. You will face many opportunities and challenges. And I once again greet you for the same and wish you good luck. I too am adapting all these things. Like we have made this application for the health of the children, where the parents can record their health, wellness, memories, and keep the children's record of their tension during the examinations. Many screening tools. Similarly, you people keep learning, keep learning. Today's seminar with the IMA, MSN, Haryana, and Dr. Punita Sija is also going to join this seminar. I wish you good luck. Thank you giving me the opportunity. See you again. Thank you very much.
Thank you so much, sir. Your speech was really insightful. We are so grateful to have you here today. Your mottos like Garb se Gotak and for the parents by the pediatricians has truly encouraged us. Now is the time that we all have been waiting for. Today is Ovarian Cancer Day, 8th of May. We have Dr. Nupur Sharma with us, who's our presenter for today. Dr. Nupur is an IVF specialist. She is an obstetrician and a gynecologist. She is the director and HOD gynae at Advamed Hospital and Ad Baby IVF Center in Chandigarh. She's the co-founder of NAMATA, which is Nadkarni Advamed Medical Training Academy, where they're training doctors nationally and internationally. She's the North Zone coordinator of regenerative and aesthetic functional gynecology. She is the ex-president of Chandigarh Region Menopause Society, working actively on women's menstrual health, hygiene, uh, creating awareness about PCOD, PCOS. She's the ex-executive committee member of COGS, which is Chandigarh Obstetrics and Gynecology Society. She's the patron of We the Women Earth. She is the founder of We the Women Earth. She's the trustee of Jeho Club. And most importantly, she's been working for women's health in the last 25 years with the motto for her, by her. Ma'am, we're really grateful to have you on board today. And I would just like to hand over the mic to you. And I think we can start with your presentation now. Ma'am, you are muted. Can you see my screen? Can you see the presentation?
Yes.
All right, ma'am. Ma'am, please guide me with your presentation when to move forward, and I'll
Yeah,
do the same.
please switch on the presentation. I'm not able to see.
Can you see it now, ma'am?
Yes, I can see it. Yes. She, uh, Sana, you sharing the screen or
Yes,
shall
ma'am.
I?
Ma'am, you
Can
want to share the screen? You can go ahead.
I think it's not working out. So
You can share the
probably
screen, ma'am.
till the technical glitch is done, I would first like to congratulate each and every one of you for holding this event. As I was going through the literature of ovarian cancer, I realized that the most important thing ovarian cancer is awareness, awareness, and awareness. So, IMA Haryana has taken up this on a great scale, and I request all of you to attentively listen because you are the future torchbearers. You are the ones who are going to spread the message all around and prevent ovarian cancer.
Ma'am, are you able to see my screen now?
Yes, I think you continue
All right.
next. So, coming on to the topic which has been assigned to me, what exactly do we target to cover today? First of all, what exactly do we mean by ovarian cancer? Who is at risk for it? How do we recognize the signs, the symptoms? How do we diagnose it, treat it? And the most important aspect, how do we prevent and cause awareness? Next. The ovarian cancer is called as a silent killer. Why? Because it comes without a bang, it just simply whispers. Almost 45,000 new cases every year in India. Third most common gynecological cancer in Indian women. 70% are diagnosed very late because of lack of awareness, and the 5 year survival being as low as just 30%. Precisely because of lack of awareness and the diagnosis made at a very advanced stage. Early detection can increase the 5 year survival rate to up to 90%, awareness being the first step. Next. What are ovaries? As we all are aware, these are small almond shaped structures, almond shaped organs. They are present in the female pelvis. We all have two ovaries, all the women have two ovaries. As we grow, we mature, our ovaries begin to grow and produce oocytes or the eggs in the layman term. Besides this, it also produces our hormones, the estrogen and progesterone, under the influence of hypothalamus and pituitary hormones. Next. There are three main varieties of ovarian cancer, beginning with the epithelial tumors. They constitute 85 to 90% of the cases. Why they are called as epithelial tumors is because they are arising from the cells lying on the surface of the ovary. Now, these cells can be a variety of types. They can be serous, they can be mucinous, they can be endometrioid, or they can be clear cell types because they contain a lot of glycogen, so the cells appear as clear cells. They can be arising from the egg producing cells, so which are called as the germ cell tumors. They are commoner in younger women and girls. Often they are curable with treatment. Sex cord stromal tumors, they arise from the connective tissue. They may produce hormones includes the granulosa cell and the Sertoli cell tumors. Here I would like to point out that the ovarian cancers are the spectrum which affects girls, women, ladies, the oldies, all the age groups are affected. When we talk of the younger age groups, we are talking more of the germ cell tumors. When we are talking of the middle age, we are talking of the epithelial tumors and the sex cord stromal tumors. And when we are talking of the postmenopausal women, we are talking of the hormone producing tumors, including the theca cell tumors and the Leydig cell tumors. Next. Who is at risk? How do we know that my chances of having an ovarian cancer are higher than the general public? Next. So, if there is a family history of ovarian or breast cancer, you might have heard of certain syndromes. Hereditary ovarian breast cancer syndrome, HOBC, which includes the breast, the ovarian, and the colon cancer. So, if there is a family history, the mother, sister, Masis, especially on the maternal side, are affected with such cancers, there are higher chances of developing an ovarian cancer. Then there are certain mutations. You must have heard of BRCA1, BRCA2 mutations. There are patients who have been on hormone, previous slide please. There are patients who have been on hormone replacement therapy for long use. They are also more prone because this includes the administration of exogenous estrogens and progesterones. Then there are patients who are suffering from diseases like endometriosis or PCOS. Now we know PCOS has come up like an epidemic. So we have girls, 80% of girls with irregular periods are suffering from PCOS. So they are again a high risk category. The women with endometriosis, you might have seen women who have severe dysmenorrhea. They may be facing coital difficulties. They may develop large chocolate cysts you might have heard of. So these patients are also more prone of developing ovarian cancers. Women who are always, who've never been pregnant, the nulli gravidas, again they are at higher risk. Women by the reason of age, women above the age of 50, again they fall in the high risk age group, especially because the ovarian cancer maximum of patients are between the age group of 60 to 65. It is important to note that women with first degree relative of ovarian cancer or BRCA1, BRCA2 mutations, BRCA1 being more important, having a 35 to 46% lifetime risk, and BRCA2 mutations having a 13 to 23% higher lifetime risk. Even the Lynch syndromes, they have 12% lifetime risk. However, this is nothing to scare you. When we talk of the general population, the lifetime risk is about 1 to 2%, which dramatically increases with these high risk factors. Then obesity, again, BMI more than 25, again predisposes to a higher chance of ovarian cancer. If we think in general terms, when the ovary ovulates, every time there is some inflammation, there is some tissue damage, there is some cell modification, it predisposes to a higher chances. All the reasons which suppress ovulation, whether it is breastfeeding, lactation, pregnancy, late menarche, early menopause, vis-a-vis early menarche and late menopause, they serve as risk factors. So anything which suppresses ovulation would decrease the risk, whereas anything which increases the ovulatory cycles would increase the risk. Next slide. Next slide. So what actually protects? We just discussed anything which suppresses ovulation. Maybe the oral contraceptive pills, pregnancy, 9 months of amenorrhea, one go, breastfeeding, patients may be amenorrheic for 2 years at one go, even tubal ligation, it decreases the risk of ovarian cancer. Next slide. So, what are the signs and symptoms? Next. It's important to note that the symptoms of ovarian cancer are very mild. That is precisely why people are able to diagnose it only in late stages. Simple symptoms like persistent bloating or abdominal pain, which is new progressive, does not resolve with the usual remedies. Difficulty in eating or early satiety, feeling full even after small meals. Pelvic or abdominal pain, dragging, dull, persistent pain. It's never a sharp aching pain. It's a dragging, dull pain in the lower abdomen. Urinary symptoms. Now, some of the ovarian tumors, like the mucinous tumors, are mammoth tumors. They are huge. So, by virtue of their size, they compress upon the urinary tract, causing frequency of urination or recurrent urinary tract infection. The rule of thumb, as stated by ACOG, is if any symptom occurs more than 12 times per month for less than 1 year, you must consult a doctor. Next slide. So, what are the other warning signs? Unexplained weight loss or weight gain. See, cancer cachexia is known to occur, and in ovarian tumors, it is even more important. Menstrual irregularities. So many of them are hormone producing, the germ cell tumors, the theca cell tumors. Patients may present with postmenopausal bleeding, or in the reproductive age group, they may present with irregular menstruation. By the virtue of the pressure of the tumor, patients may experience dyspareunia, they may experience backache, as well as the urinary symptoms we just discussed. Next. So, when do we see the doctor? If the bloating, pelvic pain, urinary urgency, early satiety persists more than 12 times per month, does not respond by usual remedies, we should consult a gynecologist promptly. Next. How would you detect it once the patient reaches us? How would you do it? Next. So, the first thing, as you must, you are doing it almost daily, taking the history of the patient, a detailed history is required, which includes not only the symptom history, but also the family history and a detailed menstrual history. After an history, we would do an examination, the gen physical examination. A pelvic examination by manual is very, very important in such cases. Then a simple ultrasound, preferably a transvaginal ultrasound. It is first line to diagnosis of ovarian mass. It will tell us about the morphology, the size, the vascularity. In fact, nowadays we have tools, we have the iota scoring of the ovarian masses, by which we can just by simply doing an ultrasound know what we are dealing with. Even a trans-abdominal ultrasound, because many of them, like the mucinous, the serous, they are mammoth tumors. So you just put the probe on the abdomen and you are able to make a diagnosis. Then certain tumor markers. The age-old gold standard, CA125. I'm going to talk about it again. The newer marker that has come up, the HE4, AFPs, LDH, and beta HCG, depending upon the clinical suspicion. Supposing we are suspecting a germ cell tumor, the marker would be different. In serous tumors, it is a CA125, which is elevated. If we are talking of the other tumors, the AFP would be important. And even the tumor markers which represent the gut tumors, like the CA19.9 and CEA, are equally important, and we go ahead with them. Then a CT scan and an MRI. You know, it is before you operate upon the patient, you should know the extent of disease, the lymph node involvement, is it having any mets, before the surgery, before the management, the exact extent of disease has to be clearly defined. We may opt for surgery as first option, we may opt for chemotherapy as the first option, depending upon the extent of disease. And histopathology, intraoperatively, we do a frozen section, and postoperatively, definitely the biopsy of the tumor mass, which we have removed. Next. So, what exactly is CA125? CA125, we know it's elevated in epithelial ovarian tumors, almost 80% of them. The problem with CA125 is that it is a non specific marker. You would find a report that it should be less than 35 in normal patients. But in endometriosis, in fibroids, in liver disease, and even infections like tuberculosis, we can have CA125 values even as high as nearing 200. But anything beyond 200 is clear cut that we are dealing with an ovarian malignancy. However, anything between 35 and 200, we should definitely look for other markers, especially endometriosis and tuberculosis in our Indian scenario. So CA125 should never be a standalone marker. In fact, it is used more for prognostication. So if a patient has got a CA125 of say about 1000, and then you've treated her, then you would monitor the CA125 becomes negative, and then you keep on monitoring the patient to know the recurrence of the disease, the response to treatment by the CA125 level. Now, the newer marker that has come up is the HE4. It is human epididymis protein 4. It is highly specific rather than CA125. And Roma score, which we do for all ovarian malignancies, it combines CA125 with HE4 to risk stratify the pelvic masses, and definitely endorsed by AGOE guidelines for pre-operative evaluation in India. Next. Next slide. So, what are the stages we are talking of? When we talk about grossly, anything which is confined to the ovaries is stage 1. When it extends in the pelvis, it is stage 2. If it goes to the peritoneal or the lymph node spread, it is stage 3. And distant mets is, of course, stage 4. Next. How would you treat it? Definitely, a multidisciplinary approach is required. A gynecologist who diagnoses, a gynae oncologist who gives the chemotherapy, a gynae oncosurgeon who operates upon the disease. The entire team is important in managing the patient of CA-open. Next. So, what exactly is the treatment? Our first choice is surgery, unless until the tumor is stage 3C or there are distant mets where the chemotherapy may remain the first line of treatment. Tumor debulking. The debulking, complete tumor removal, is the single most important prognostic factor. Our aim is to have no residual disease. However, in younger women with early stage germ cell or borderline tumors, we preserve one ovary and the uterus. In fact, I recently had a patient. She had a mucinous cyst adenocarcinoma. She was operated. Her one ovary was removed, the other ovary was inside, the uterus was inside. We were able to give her a pregnancy by her own eggs through the other ovary. So it is important to understand the fertility status of the patient. Is her family complete or is she still unmarried? Are we talking of oocyte cryopreservation? All these things have to be thought of before we finally plan her surgery. In case the tumor is widespread, stage 3C, then definitely 3 cycles of neoadjuvant tumor chemo will shrink the tumor, and then we go ahead with surgery. Surgery definitely involves the total abdominal hysterectomy, the bilateral salpingoophorectomy, omentectomy, lymph node dissection, and peritoneal biopsies. But whenever we take up the patient for surgery, as I discussed in the previous slide, a multidisciplinary approach involving the gynecologist, the fertility specialist, because fertility conservation is very, very important in today's time. The oncologist, the this thing, oncosurgeon, the radiologist who's making the diagnosis, a good ICU team, because many of these patients they require post-operative ICU, especially when they're undergoing chemotherapy. That's again the time when their electrolytes go imbalance. They might become very low at times, and a good ICU backup is required. Next. So, what chemotherapy do we give? Simple carboplatin and paclitaxel 6 cycles IV. That's a gold standard as per ACOG and COE, has been there since years. But now we have newer drugs like Avastin. It's an anti-angiogenic agent added for advanced or recurrent disease. It targets the vascular endothelial growth factor to cut off the tumor blood supply. New kid on the block are the PARP inhibitors like the olaparib, niraparib. They are used for maintenance therapy for the BRCA mutated or the platinum sensitive recurrent disease. This is a major recent advance, especially for the maintenance therapy. Once we have treated the patient, we do not want the recurrence, because recurrence again is a very big problem. So these PARP inhibitors are the ones which really play a very important role in the maintenance therapy. Next. So, who should be tested for BRCA? Any idea? Just let's tickle our brains. All women who are diagnosed with epithelial ovarian cancer should be tested for BRCA. Women with first degree relative with ovarian or breast cancer. As I say this statement, many of you would sit down and think, आप सबकी कितने फर्स्ट डिग्री रिलेटिव, कितने जने यहाँ पर होंगे जिनकी मासी को, जिनकी बुआ को, मदर को ब्रेस्ट कैंसर हुआ होगा. We all become candidates for BRCA testing. Even if the primary candidate, supposing the Masi has been operated for CA breast before age 65, or Masi has been treated for ovarian cancer, and she has not been tested for BRCA, we can still undergo BRCA testing. It is a very simple blood test. Nowadays, it is very economical also. Why it is important to test for BRCA? Because the patients, if they are tested, they will qualify for the PARP inhibitor maintenance. Then the family members can undergo a cascade testing, and BRCA positive candidates, they deserve more intensive screening. They deserve prophylactic oophorectomy to reduce the risk of the cancer forming later in life. Next. So, when it recurs, what do we do? Again, our gold standard chemotherapy, platinum resistant or platinum sensitive, treated differently. And how frequently do we follow up our patients? Every 3 months for 2 years post treatment is recommended by the CA 125 levels, the clinical examination, and a transvaginal ultrasound. Next. Can we prevent ovarian cancer? A question open to the house. Next. We are all here to prevent it. That is why we are all here. By educating ourselves, by screening ourselves. If we have this, we are knowing whether we are BRCA1 mutation carriers. However, that doesn't mean that each one of us undergoes a BRCA testing. It is only when there is a strong family history, then we undergo a BRCA testing. Next. So, once we are BRCA positive, a genetic counseling, enhanced surveillance. Once the family is complete, we have a prophylactic salpingo-oophorectomy, and an oral contraceptive use will again decrease our risk. Next. Anything we can do in routine? A healthy weight. BMI more than 25 is responsible. It's one of the risk factors for ovarian cancer. Maintain a BMI, healthy BMI between 18 to 24.9. Regular physical activity, almost 150 minutes a week is recommended. Avoid all carcinogens, which include the tobacco, the alcohol. A healthy diet, high fiber, plant rich diets with cruciferous vegetables. They offer some protective benefit. All kinds of processed foods, frozen foods, fancy cooking in microwaves, these smoking, this barbecuing, all of these, they increase the chances of ovarian cancer. Next. Why India has higher mortality and higher morbidity due to ovarian cancer? Because we attribute these vague symptoms to gastrointestinal discomfort, and most of the women are diagnosed 70% in stage 3, stage 4. That is why we are losing our women to ovarian cancer. AGOI emphasizes urgent need for public awareness campaigns. As you have already taken a lead, you already conducted an ovarian cancer campaign. Everybody is talking about cervical cancer, but I think the this Gulabi Punk wing of IMA is the first one who is talking about ovarian cancer. Really, a big congratulations. You are already first step ahead in prevention of ovarian cancer. Next. So, we've already talked about the centralized care, community awareness, expand BRCA testing, strengthening the primary care as recommended by AGOI. Next. And for MBBS students, whenever a patient comes to you, new onset bloating, pelvic pain, urinary symptoms, especially the age group above 40, put ovarian cancer in your list, not the first on list, the last on list, definitely. Do not miss any vague symptoms. Do not always put it on IBS or stress. Refer early and appropriately. Make liberal use of a pelvic examination and a TVS examination, CA 125 and HE4. Next. Some people feel that if we do a pap smear, we can screen for ovarian cancer. I think now the message is very clear. Pap smear is for the cervical cancer screening and not for the ovarian. People think that elderly women can get it. We just discussed the teratomas are commoner in the younger women. So, and women of all reproductive age groups are affected, not only elderly women. A family history means you will definitely get it. Of course not. There are 30% increased chances, but not 100%. Next. So these are few of the real stories. I thought bloating was normal after 50. My gynecologist caught the tumor at stage 1. I'm cancer free now 5 years. That's a 54-year woman speaking from Chandigarh. Early diagnosis, it's a cure. After my mother's ovarian cancer diagnosis, I got BRCA tested. I was positive. I had preventive surgery and feel empowered, not scared. So this is what BRCA testing does to you. It encourages you, it empowers you. It's not meant to scare you. So if you diagnose it early, you can treat it. Your vigilance can save your life or someone you love. Next. 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 So together we can turn the tide on ovarian cancer. Yes, we can. I think that's the last one. Thank you. The house is open for questions.
Uh, Thank you so much, ma'am. This session was so insightful, and you also shared some real life cases with us. They gave a lot of hope to people. I think it has always encouraged, IM has always encouraged us to work towards issues. I heard that very recently, I think around mid of April, you had also raised awareness on cervical cancer at Sukhna Lake, Chandigarh, and it was all over the papers. I don't know how to express my gratitude to you because you've been doing great for the society, especially with your presentation. At least me being an MBBS student, I am very clear about how will I see if a patient comes to me with ovarian cancer and I can guide them to a gynecologist. Uh, I think we have a few questions that we have received by people and we want to address them via an expert and who would be better than you to address them. I'll give the floor to Amira. She's going to ask you the questions, and it'll really mean a lot to us if you answer these questions. We have 91 people currently watching you live with their questions and waiting for you to respond. Thank you, ma'am.
Before we begin our Q&A round, I'd like to mention that we received several thoughtful questions from the members of the audience. To respect everyone's privacy and maintain anonymity, I will be presenting these questions without mentioning the names of those who submitted them. With that, let's begin. Our first question to you, ma'am, is in your OPD experience, what is the most common presenting complaint in ovarian cancer patients?
So most of the patients that come to us, they would call, they would tell us vague symptoms. They would say कि खाना नहीं पच रहा, I feel very bloated, I don't feel like eating. So, and most of the times they might actually be going to a physician or a, general practitioner for their symptoms. It is only once they do not respond to the treatment given by the general practitioners, the routine PPIs, the antacids, that they report to us. And believe me, once we take them on we just tell them to lie down on the examination table, and so many times incidentally we find a large mass which is occupying the whole of the abdomen. So that is something, it is usually an incidental finding in the OPD once they are coming with the just vague symptoms.
Thank you, ma'am. The second question is in women who are considered high risk for ovarian cancer, what surveillance or follow-up strategy do you usually recommend in your clinical practice?
So we begin right from their reproductive life. Around 30s, they can start monitoring themselves. They are definitely careful, but I don't want them to be tense about it. I just want them to be attentive about it. So, a 6 monthly clinical examination, a transvaginal ultrasound would be fair enough. What being watchful for any new onset symptoms, these vague symptoms, if they persist and they are troublesome, or any menstrual irregularities, they report in between. Otherwise, beginning after 30, 6 monthly checkup with the gynec should be fair enough to diagnose it at an early stage. And then definitely the
Thank you.
CA125 marker, because so many times, it's easy to get a whole body check done than visiting a doctor. All of us, we are very fond of कि एक बार सारे whole blood test करा लेते हैं once a year. We gift ourselves on our birthday. So a whole
Mhm.
body check, or now you people are all budding doctors on Doctors Day. So lot of lab people would be coming to you and saying कि Doctors Day वाले दिन मैडम आपके सारे टेस्ट they are free of cost, तो आप करवा लीजिए. So that time this CA125 is a real help. Just get that CA125 done. Normal, it kind of reassures because you're talking about 80% of the ovarian tumors.
Right. Thank you, ma'am. The next question is, even after successful treatment, many survivors continue to live with the fear of recurrence. Could you share what the chances of recurrence generally look like and what lifestyle changes, preventive measures, or precautions may help reduce that risk?
So when recurrence depends on the stage. If it is just stage 1, the chances of recurrence are just 10 to 25%. Vis-a-vis in stage 3, 4, they are as high as 90%. So, depending upon what stage it was diagnosed, we would prognosticate and tell them the recurrence risk. Most of the recurrences, they occur within first 18 months of treatment. So that is a time where they really need to watch themselves very carefully. Coming to the prevention, because once we have a family member suffering from it, the rest of the members become very careful. So what advice at the same time we give to the family members is, one is, if they are obese, lose weight, daily exercise, avoid junk food, avoid processed food, avoid smoking, alcohol, tobacco in any form. All these things, they would automatically bring down our risk. And then one very important advice we give to young girls, when they walk in with their mothers is, get married soon, produce kids soon, because nowadays everybody is delaying childbearing. And as we say, the pregnancy, lactation, they are all protective factors for breast cancer. So if they get married early, they produce children, after all, almost 2 years of amenorrhea they experience once they are lactating, that again will protect them. And then definitely the regular screening and all is recommended.
Thank you, ma'am. The next question is, from your experience as a clinician, what is one mistake young doctors commonly make when evaluating women who present with persistent abdominal complaints?
What I personally feel is that young doctors, they may not like to touch the patient. You know, many of them, you would be doing your internships, you would be sitting in the PHCs, your rural postings. So once the patient comes to you, you would be simply sitting across the table, and the moment they say कि मुझे gas हो रही है, खाना नहीं पच रहा, everybody is very fond of writing the PPIs and laxatives. You know, if you just simply make the patient lie down and do a simple bimanual examination, even if you are not very good at doing your PVs, you will still be able to feel a mass. So, a 5 centimeter mass, none of you will miss in a per vaginum examination. So, this is, I think, what we should all start do. Try putting a Cusco speculum, utilize the opportunity to take a pap smear, HPV co-testing. You have protected, you have screened her for cervical cancer. A simple bimanual examination will tell you if she's carrying any ovarian mass. And so many times the patient actually has a mammoth tumor as big as a full term pregnancy, and she's not even aware of it. So always touch your patient. You will not miss ovarian cancer.
Thank you, ma'am, for the advice. I'm sure we all appreciate it as budding doctors. It was very much so needed. Due to a shortage of time, now we will have the last question for the evening. Discussing prognosis can be one of the most sensitive parts of patient care. How do you explain prognosis to patients and their families in an honest yet reassuring way without causing unnecessary fear?
Patient counseling and the family counseling both form an integral part of the cancer treatment. The most important aspect is spending time with them. These are not the patients whom you would just see in your busy OPD. You give them special time, sit down with them, give them statistics, and tell them real life stories. Connecting the patients with the survivors is a very, very promising approach. So, as you are telling them the statistics, as you are telling them the chances of recurrence, you make them meet the survivors, they are automatically positively motivated. And every patient is individual. Your statistics may not hold true for that patient. So never ever make them lose hope. Empower them with knowledge, but maintain their hope.
Thank you so much, ma'am, for answering all our questions so patiently and taking this wonderful and meaningful session. Now, I would like to hand over the mic to Sana to conclude the meeting.
Thank you so much, ma'am. First of all, I wanted you to answer two, three more questions. We had received a lot of questions in the chat box on live, and very kindly, Mihir sir has given us two, three questions out of them which can actually be answered in during the brief duration of the meet. First question is, ma'am, Priya is asking, in which way do we sensitize poor women? Uh, Regarding this, since it's very easy in urban areas due to emerging corporates, it is very easy, people go and get themselves tested, but how do we bring this change in the rural areas?
See, all of you, now I am addressing the young doctors. So, all of you would have your rural posting. So, your rural posting is not just meant to sit in the PHC, it is meant to go and interact. So, when you go for your rural posting, जो इंटर्न है वो पीएचसी का राजा होता है. तो अगर आप अपनी टीम को पहले से सेंसिटाइज करते हो कि आज मुझे पूरे गांव की 50 औरतों को बुला दीजिए और मुझे उनसे बात करनी है, तो आप लोग डेफिनेटली बहुत बड़ा चेंज लेके आ सकते हो. So that is one aspect, because I am working with Indian Menopause Society and I am one of the member of the rural awareness program. And this is how we are trying to reach the masses. Every village, they have a punch, they have a sarpanch. And believe me, it is very difficult to gather urban people on a physical platform, whereas gathering rural people on a platform is very easy physically. Then everybody in the rural has got mobiles. So if 90 of us we are watching this, we are all sitting together to talk about it. If we just simply put it up on our WhatsApp status, you people are better, you people are the Gen Zs. So lot of these rural people are going to see and ask you. And once they ask you, I'm sure you're going to educate each and everyone. So rural are also well connected. It's just a block we have in our mind. But I think you Gen Zs will, Gen G or Gen Z, I don't know what you call. You guys are going to do it.
Thank
Definitely.
you, ma'am. One more question I think we can take it again asked by Priya. This is Priya Sharma. Why is ovarian cancer diagnosed at a late stage despite the modern diagnostic methods? Why are we not able to detect it at an early stage?
Because simple reason, because the symptoms are so vague that we do not investigate. हर बार गैस की गोली खाना is not the answer. Persistent bloating, persistent indigestion, persistent weight loss. We need to think of ovarian cancer. It has to be a differential diagnosis. So that is the reason, because we don't think of it. We diagnose when it presents in terms of large masses. That is very important.
Very rightly said, ma'am. As you know, the famous saying, eyes can only see what the mind knows. So, as long as all of us as bedding doctors are aware of ovarian cancer, the symptoms, and how to diagnose it, our eyes will be able to see it. And this meeting has made it so easy for us to actually see a patient in a way that they might have ovarian cancer. And you've also taught us not to scare the patient with it and be a little patient our own selves so that we can
एक और
treat
बड़ी
them.
इंपॉर्टेंट बात आपको बतानी है कि जैसे आप अल्ट्रासाउंड कराओगे, बहुत सारे पेशेंट की ओवेरियन सिस्ट आएगी. अब कितनी बड़ी सिस्ट को इम्पोर्टेंट मानना है? एनीथिंग विच इज मोर देन 5 सेंटीमीटर इज समथिंग विच इज इम्पोर्टेंट. Secondly, the qualification of the cyst. Does it have any solid areas? How vascular it is. What is the look of it? How angry looking it is? There are so many parameters. I don't want the entire house to think कि अगर अल्ट्रासाउंड में ओवरी में सिस्ट आई है तो वो सारी कैंसर है. बिल्कुल भी नहीं. कितनी बार होता है फॉलिकुलर सिस्ट होती है. lot of patients are taking ovulation inducing drugs. Even a simple follicle, 20 mm का follicle, 25 mm का follicle हर महीने हर cycle में बनता है. And sometimes when patients are on ovulation inducing drugs, they may have follicles on both the ovaries. So just by looking at that, do not label your patients having ovarian cancer. Do not do unnecessary CA 125. So see if it is persisting. You would repeat the ultrasound post menstrual. A mid cycle scan would tell you even a follicular cyst will look like ovarian, of an ovarian cyst. खासकर जो perimenopausal women होती है, there the follicle does not rupture and they land up with an follicular cyst. So every ultrasound में ovarian cyst is not cancer. So many times, 90% of the times, these are simple cysts amenable to simple treatment like oral contraceptive pills, and they would go off in the next cycle itself. So don't scare also. And so many of them are benign. Ovarian tumors are mostly with the borderline malignant potential. So many times there will be dermoids. सो सारे कैंसर नहीं होते. सिर्फ हमने अपने बैक ऑफ माइंड में रखना है. दिस इज नॉट समथिंग विच इज गोइंग टू बी इन फ्रंट ऑफ आवर माइंड, बट इन बैक ऑफ आवर माइंड. yes, it could be ovarian cancer cachexia and a large mass. These are the things which should actually alarm us. पेशेंट से हमने तब तक कैंसर वर्ड यूज नहीं करना जब तक हम उसको डायग्नोज नहीं कर लेते.
All right, ma'am. Points well noted. One more question. I think this will be the last question that we'll take since we are getting so many. Ma'am, we just want you to elaborate BRCA testing. This question has been asked by Shreya Stephen. I think, I assume that she is a budding doctor. She just wants to know a little more about BRCA testing.
See, most of the laboratories, BRCA testing, ideally, first the index case should be tested for BRCA, whether she is a breast cancer or she is an ovarian cancer patient. एंड जस्ट इन केस द इंडेक्स केस हैज नॉट बीन टेस्टेड. अब यहाँ पे जो हॉल में बैठे हैं बहुत सारे लोग होंगे जिनके फर्स्ट डिग्री डेरिवेटिव को ब्रेस्ट कैंसर हुआ, ओवेरियन कैंसर हुआ, उनका ट्रीटमेंट हो गया पर कभी डायग्नोसिस नहीं हुआ और वो विलिंग भी नहीं है ब्रेका टेस्टिंग के लिए. तो at random जो बाकी family members हैं, first degree relatives हैं, they all can be tested for BRCA. It is a simple blood test, not very expensive these days. All the good labs, whether it is Lal Path Lab, SRL, they are doing it. So, and at a meager cost. So, no, if you're talking of cost of 7,000, 15,000, it is meager depending, looking at the cost, the amount of money we are spending on ourselves routinely. So, if we are BRCA positive, then we know that yes, we are at higher risk of developing ovarian cancer than the family history alone, and we would undergo more frequent screening. So, it's a simple blood test.
Thank you, ma'am. Also, I would just like to
It's a
highlight the
genetic test.
fact
Hmm.
that the color of ovarian cancer is teal, and I think the closest color that we could find to teal is blue. And the entire team is wearing blue. I never thought that everyone will turn up wearing blue, including Dr. Nupur. Ma'am, it is when I requested you to wear blue, I was feeling shy myself that you being such a reputed person, what am I even requesting you to? But I am so happy that even you are wearing blue. One more thing, ma'am. Uh, we want to know that since you are an IVF specialist, you have your own IVF center. Ma'am, with women having ovarian cancer, is it also that they can never be mothers? Or do you have a way? Are you practicing something at Ad Baby at your own center?
See, first of all, we have to understand whenever we treat a patient of ovarian cancer, is her family complete or not? So, if she is a patient who has just been recently married, she may have just one child or she may need another child, she may not have a child at all. Then, for our treatment, even before we start her chemotherapy, we plan her surgery, we first do an oocyte cryopreservation because at least the contralateral ovary is going to give us the oocytes. So we stimulate her and start the IVF stimulation, pick up her eggs and preserve her oocytes. This oocyte cryopreservation is endless. You can keep your oocytes for n number of years, and the minimum number of oocytes required is about 10 to 15 is required to be fruitful later in life to result in a healthy pregnancy. Next step is when this is even before we put them on chemotherapy, because once we start chemotherapy, the ovarian reserve is definitely going to fall down. Secondly, the type of surgery we are going to do. Uh, a debulking surgery is recommended, but in patients who are desirous of fertility, we would do a limited surgery. Like I just discussed, a patient with a large mucinous cystadenoma. It was almost a 20 centimeter mucinous cystadenoma. We operated upon her. Then we did her ovum pickup from the contralateral ovary, made the embryos, did the embryo transfer, and she's already gravid with twins almost 33 weeks now. So there is another patient who had a surgery for mucinous cystadenoma at PGI long ago, came to us, and we put her on IVF treatment, and she's already conceived and delivered. So, ovarian cancer does not mean the end of your fertility, it just means how well you manage it. Incorporating a fertility specialist in your multidisciplinary approach right at the diagnosis will enable you to preserve her fertility. It just takes 12 days to preserve her oocytes. और 12 दिन तो आई थिंक ये सारी टेस्टिंग में भी निकल जाते हैं, इतने दिन हमारे लिए बहुत है एग्स प्रिजर्व करने के लिए.
Oh, very well answered, ma'am. One of the reasons I'd asked this question is because you yourself are one of the leading institutes practicing IVF in North India and especially Tri-City. Uh, you are running at Baby IVF Center, as per what your team told me, since a very long time, since I think 2008. And you've been doing great for the society, treating women with ovarian cancer and much more infertility issues and blessing them with the joy of motherhood. uh, your motto Garbh se Gotak was also highlighted, and it's beautiful. Parenthood is something which has to be nourished and cherished, and you're making it accessible to everyone. We are just truly grateful to you. considering आजकल तो infertility बहुत बढ़ गई है because of the rising substance abuse and smoking, alcohol, late marriages and everything. I think we'll also put a brochure about Ad Baby in the chat box. People have a lot of queries. One more thing, ma'am, that I want to ask to you is, we had also heard about your association with the Nadkarnis. They're working very actively for cancer.
Yeah.
उनका मोटिव ही यही है कि making cancer care accessible for the poor. And I just saw, I came while I was seeing you on social media to write about you. I saw a post of you with Dr. Akshay training students at Tamata. Can you just give an insight into what you are doing for the society? I think
See,
everyone would be
our
interested.
center is offering trainings to doctors, budding doctors like you. Because as you grow up, you would decide that I want to become an IVF specialist, I want to become a laparoscopic surgeon, and nowadays the latest kid on the block is the aesthetic gynecology. So this is where what trainings play a very important role. These are not the things you would just learn by reading books. A hands-on experience is very important, and this is what we deliver at Namata, that is Nagpurni Advamed Medical Training Academy. We hold biannual training classes, 7 days, 3 days training sessions, where we make them physically work. You people actually operate, but then for that you have to be practicing basic laparoscopy. Then aesthetics, it's a beautiful field where we are using lasers, we are using HIFU, where we are using this all these peels and all to make the genital area beautiful and more functionally active. So many people women have their stress urinary incontinence. All these symptoms are treatable now, and a lot of women, they face cosmetic issues at the genital tract also. So we are dealing with those also with compassion and care, without judging. It's very important not to judge our patients and offer this care also to them, because the parlor peoples are not the ones to offer this. It is the hardcore aesthetic gynecology which is required.
Thank you so much, ma'am. The one of the best part is that you have an association with the Nadkarni family, Dr. Akshay Nadkarni, working extensively for people in cancer care and at a very minimal cost. And I think we are grateful that we have gotten the opportunity to collaborate with Advamed Hospital and have you on board. It has been our immense pleasure. I won't take a lot of time. I would just ask you, do you want me to ask one more question from the chat, or should I just end this here?
I think your team must be tired. It's a long session. We would just wind it off. And I'm highly privileged and thankful to all of you for being there, and being such a patient audience who've been participating, smiling all throughout, not getting irritated, and enjoying the session. So,
Thank you, ma'am.
with
We
this, I
had
really thank all of you to invite for the privilege of inviting me to be a part of you all.
thank you,
And
ma'am. We had more than 100 people seeing you live. I think they've taken a good take-home message home, and we'll all be more responsible citizens paying well to the society now. Thank you so much, ma'am. Thank you so much.
thank you.
Uh, All right. Can we now, we are still live. Everyone, for the certificates of the event, I would like to first, before the certificates, I want to thank all my seniors who have guided us, holding our fingers through this event. I would especially like to thank Mihir sir, who's been at the back end, streaming everything to you all, bringing it to you all, and also helping me to organize the event. I would want to thank the convener of IMA-MSN, Rohan sir. I want to thank Parisa ma'am, who's the coordinator for this month. I want to thank Kamal sir, and especially my hardworking team. When we conceptualized, as I said, we barely thought that we'll do a good webinar, but we are so grateful that you guys turned up. It means the world to me and my team. Uh, Coming forward, I think we are done with the webinar. For the certificates, everyone, you all will be shared a WhatsApp. On the WhatsApp group, everyone will be shared a Google Form link. This link is active from 7:17 to 7:27. Amira is sharing it. Everyone who fills their details on the link will receive a certificate within the group. So please do not exit the WhatsApp group, as it is a very time bound thing. Also, please don't share the form across anywhere. The team has been monitoring the participants and their email IDs, so it'll be all tallied before giving the certificates. So please make sure that it is done in a very systematic manner. So the link is active. We'll stay on the meet, and once it is 7:27, we'll end the meet after a thank you note to everyone. And once everyone has filled their Google form for the certificates.
The Google form has been shared.
Everyone, the Google form has been shared. You have exactly 10 minutes to fill it. I think the team can wait till 7:27 and then we'll all leave. Amira, the queries that we are receiving, there are a lot of people sending me queries on WhatsApp about the certificates. Please answer them once you get them. I'm just forwarding it to you. People who are not a part of the WhatsApp group, please note that it was compulsory to be a part of the WhatsApp group to receive the certificates. Um, Again, for the queries, you can still text in the chat box. Our team will look into it with your numbers. If you have attended, we'll still send over the certificate. But make sure you're a part of the group now. Oh, hi team. I think we'll be turning the live stream off. Thank you so much to each one of you who's joined us today. It means the world to us. Trust me, the amount of effort that has gotten into organizing this event has been a huge milestone for all of us. I am grateful that you all were a part of it, and I think Gulabi Pankh is now, for this term, going to bring you such events which are much more insightful. And the motive was to create awareness and take a message home to help the society. And I feel like every one of us should take the responsibility to go and teach five more people at least about ovarian cancer and spread awareness. At the end, boon boon se sagar bharta hai is what we have heard. So let's work on ovarian cancer and try, obviously not to eradicate it, but at least make it curable for everyone. Thank you so much, everyone, for joining. I think the team will now be switching the live stream off. Thank you so much. Are we still on live stream?